Good evening. I'd like to welcome everyone. My name is Dr. Andrew Cohen, and I am a comprehensive restorative dentist outside Philadelphia. I'm also visiting faculty at Spear Education in Scottsdale, Arizona, and a diplomat in dental sleep medicine. I think it's critical providers are aware of their patients' potential for undiagnosed sleep-related disorders. We often get to see our patients more than their own primary physicians. This gives us an opportunity to help our patients and improve their quality of life. Proper sleep is necessary for optimal health. Sleep disorders have the potential to severely impact our patients' health. My goal in this webinar is to help each of you be better able to recognize patients who may have a sleep disorder. Please feel free to type any questions and I will do my best to answer them. So let's begin. How do you find patients with a sleep disorder? Well, I think it's important that we listen to our patients. We have to look at them. And I think if you do both, you can understand them and start to see different issues that they may have. So this is so important because there are so many health-related issues that are linked to poor sleep. It's a hot topic right now, and you need to be prepared for your patients to ask. The big five are sleep issues or have been clearly linked with heart attacks, strokes, Alzheimer's and dementia, high blood pressure, and cancer. I want to be able to help my patients prevent any one of these. So these patients are already in your practice. They have wear, TMD, and other health-related issues. So let's find them. The choke point is usually in one of three places: the nose, the mouth, and the throat. These are the things that we look at each and every day with all of our patients. The key is to find that choke point, and we can do that with our exam. Just by asking questions, just by listening, we can find and see the clues. So I have four components of my exam, whether it's a hygiene check, whether it's a sleep patient, or whether it's one of my restorative patients. Because I want my dentistry to last, and I want my patients to be healthy. My four components are asking about their medical history, our dental exam, asking sleep questions, and imaging. We already are probably doing two of them. I ask that if we just ask a couple questions about their sleep and we take some additional imaging, we can get so much more information. So when I'm looking at a patient's medical history, the first thing I want to look at is I want to ask them what medications there are. And some medications make me think, could this patient have a sleep disorder? So high blood pressure medications. And when I have patients that they're on more than one medication, it really makes me ask why. Because sleep disorders cause vasoconstriction or narrowing of the blood vessels, and that's going to increase your blood pressure. And there's been plenty of studies that show that patients who are on CPAP and have treated sleep apnea, their blood pressure actually goes down. Patients with anxiety and depression, those medications that many of our physicians put us on, they can severely affect our sleep cycle. Cardiac meds, sleep aids, these are all medications that make me ask more questions. And what about medical issues? Some of these are automatics. If I have a patient with AFib, Alzheimer's, reflux, heart failure, they have to get some sleep screening because of the strong correlation with them. And AFib especially is very, very dangerous because our patients don't want to go into an arrhythmia. Dental history. So what are some things that we look at in our history and our exam that make us think of a sleep disorder? Well, pathway and erosive wear, your patients that have chronic muscular or joint issues, headaches and migraines, your patients that are tongue-tied, which we'll get to in a little bit. I'm going to look at tonsils, and I'm going to look at skeletal deficiencies. Now, there are three areas that I'm looking at. Your vertical dimension, which is from the top down, your transverse dimension, which is from the left to the right, and your anterior posterior dimension, which is from the front to the back. My sleep history, I'm just going to ask questions. Do you gasp? Do you ever wake up and choke? Has anyone told you that you're snoring? Do you have trouble going to sleep? Do you have trouble staying asleep? Do you wake feeling unrefreshed? Are you tired during the day? Do you make frequent trips of going to the bathroom during the night? Patients with sleep disorders, when they wake up from not being able to breathe properly, their body can register that their bladder is not empty. So while they normally would sleep through the night, if they get to a stage of awake, their body will tell them to go to the bathroom. And lastly, clenching and grinding at night. This is a big one because it's one of our body's reactions to poor sleep is to help us to wake up through grinding and clenching our teeth. We used to think that clenching at night was due to stress. There's been a lot of studies that prove or show that clenching and grinding during the night is related to a sleep disorder. Imaging. Well, I can tell you that I cannot practice anymore without my CBCT. I love getting insight into what the hard tissue is doing because I can really be able to see the skeletal deficiencies. I can look at a deviated septum. I can look at their airway volume, and I can see pharyngeal spaces. While none of these can create a diagnosis of sleep apnea or a sleep disorder, it can help me ask questions more. So let's look at our different skeletal areas. One of the things that I do as I go through my CBCTs with my patients, I'm looking at the transverse dimension. And what I do is I draw a line from the pulpal chamber of the upper first molar to the pulpal chamber of the opposing first molar. And I'm looking, is that dimension less than 40 millimeters? And if it is, it's going to make me think the patient is constricted. Now, the picture on the right is this actual patient. And what you can see is that they're a little bit in crossbite. And that's because they're narrow. And as you can see from the diagram on the left, their dimension was only 37 millimeters. This same patient, when you look at him look at his arch, you can see how narrow he is up in the premaxilla area. And you can also see how vaulted his palate is. See, the reason why we get a vaulted palate is often related to our patients are tongue-tied. And there's 4 different classifications of a tongue-tie. Most of us know or recognize when a tongue is tethered in the front. And that's very easily snipped, and it's very important for nursing babies because it's very difficult to latch. But some posterior tongue ties, the muscle is so strong that it prevents the tongue from getting to the roof of our mouths. And we need that in order for our palates to expand. It's kind of like our body's natural orthodontics. If we can't get our tongue up there, we're more likely to be narrow and constricted and with a vaulted palate. I'm looking also for deviated septums. So this is a cross section, and clearly what I can see is a deviated septum right there. And what that instantly makes me think is, can this patient breathe through its nose? And if he can't or she cannot breathe through their nose, then the body is going to automatically default to its mouth. And if we're mouth breathing and we end up getting on our back, where is the tongue ultimately going to go? It's going to go into the throat and potentially block the airway. Our bodies want to breathe through our nose. It warms the air and it filters the air. But if we can't breathe through our nose well, our body will fight for us. We will compensate to make it easier for us to breathe. And many of our patients that we see who are mouth breathers fog up your mirror. They also are the ones who are gaggers. And why are they gagging? They're gagging because they're trying to protect their airway. And if you can help them breathe through their nose better, they're less likely to gag. I use my CBCTs because I do treat a lot of TMD. And what I'm looking at and what I believe is that your TMD and your sleep patients are directly tied to each other. See, oftentimes our TMD patients have degenerative joint disease or have muscle issues that have their condyles more posterior in the fossa. And what you see here is this patient has actual, the condyle is actually degenerating here and it's losing its volume. And what happens when that occurs is that the space between the condyle and the fossa decreases. So there's a loss in vertical dimension. And if there's a loss in vertical dimension, this can close down the airway further. I mentioned about the posterior position of the condyles. This is often seen in patients that have anterior disc displacement. Again, if the patient isn't on their disc, they've lost 2 to 3 millimeters automatically, which is the thickness of the disc. Now imagine the impact that that can have. We've all seen our patients with worn dentitions. We also know that a change in the posterior of 1 millimeter can make a 3 millimeter change in the anterior. Well, imagine if we take that back to the joint, how a change in the joint area can affect the teeth. I look at airway volume. Now, this is a static image. And what I mean by that is a patient can be breathing in during this, or they could be breathing out, and that can change the airway volume. But what I look at, or what that makes me think, is if I see a patient that has an airway volume that's 1/3 of what's considered normal, it makes me wonder, how are they breathing in that position? And what I start to look at, and what you can see from the picture on the left, is this is their tongue. This is the soft palate. And this is compressing or reducing the airway volume. This has to get out of the way in order for a patient to breathe. Because breathing issues are really caused by the soft tissue just closing down, making it more difficult to breathe. Sleep apnea is when those tissues completely close together and no air can pass. I'm also looking at the pharyngeal region. This is a cross-section that clearly shows pretty big tonsils. So if the tonsils are that large, it's going to, again, reduce the airway volume. Imagine trying to breathe through a straw. It just makes it more narrow. And the more narrow the anatomy is, the higher chance that that tissue will close and make it more challenging for a patient to breathe. So it's really important that we look even at our kids, because what we know is the earlier we treat our children, we still have the ability to influence skeletal growth, which is why many orthodontists are doing palatal expanders. And I think the benefit of expanding is it's ultimately going to help the airway. Now, this is one more for your restorative dentists. In 2016, the American College of Prosthodontists stated, due to the complexity and extensive amount of time and financial expense involved in prosthodontic rehabilitation, as well as the serious health risks of untreated screening for obstructive sleep apnea through questionnaires for their patients, prosthodontists should recognize the signs and symptoms of obstructive sleep apnea. It's here. We need to look. If we want our dentistry to succeed, if we want our patients to be healthy, we have to ask the questions and get them the proper help that they need. Well, there's good news, because not everybody has a CBCT. So I'm doing the exact same exam now, except I'm just looking at a few more things. And when I look, I'm just looking for red flags that make me want to ask more questions, red flags that make me say, is this patient at risk? So for me, it starts when the patient's walking down the hall or sitting in that chair. All I need to do is look at them in their profile, and that tells me a lot. And when I look at my patients, I can start to recognize where their potential skeletal deficiencies may be. It's the same three. I'm looking at AP, I'm looking at the transverse, and I'm looking at the vertical dimension. So what does that look like? Well, what I know is that if I can combine my clinical exam with imaging, it makes me question, should that patient be screened for sleep disorder? So my clinical exam is what you're all doing now. Looking at the condition of the teeth. I look at their nose. I look at their arch form. I'm looking at the tongue position and whether or not their tongue is restricted in their movements. I'm looking at the soft palate and the tonsils. And I'm looking, do they fog my mirror? So here's a patient that's maxillary deficient. And what this patient who has sleep apnea has to do during the day is he has to move his jaw or his head more forward. See, when we have sleep apnea, the problem follows us during the day or any sleep disorder. Our body is able to compensate during the day, while at night, we lose that ability. Actually, in REM sleep, our body becomes paralyzed or atonic. So we lose the benefit and our body has more difficulty helping us being able to breathe. Well, during the day, this is just an unconscious reflex. So he walks with his head positioned forward. I can actually look and see if I drew a line from his forehead to his chin, do his teeth hit that line? And what I'm looking at for a forward head position is where is his ear in relationship to his shoulder? And when I'm looking at Andrew's angle, I can clearly see his maxilla is completely deficient and set back. So if his maxilla is set back, what does that mean that his soft palate is? The position. It's further back. It has a greater chance to affect and impinge the airway, which makes it more challenging for him to breathe. Here's a patient with a deficient mandible. Well, the same thing can be said about the mandible. If the mandible is deficient, where's the tongue going to be? It's going to be in the back. And if the tongue is positioned more posteriorly, then again, that can impinge upon the airway. The nose. How easy is it to just look at our patients and see that their nose is going off to the right? Or when they're in our chair, we just move our mirror up and see that their nostrils are asymmetric. These are signs that there's a deviated septum. If there's a deviated septum, there's a greater chance that they have to breathe through their mouth. And at nighttime, if they're breathing through their mouth, their tongue can fall back as we become more atonic, and that could block the airway. So here's our tongue position. The picture on our left, I remember we used to call this a BFT, big fat tongue. Now I often would say, is it really a big tongue or is it actually a small mouth? The bottom line is that tongue has to sit very, very high. It's above the occlusal plane. So if that tongue is sitting up high, it's reducing our airway volume in our mouth. And when we look on the picture on the right, we're seeing indentations on the tongue, which we call a scalloped tongue. And the reason why this occurs many times is because the patient is too narrow in the transverse dimension. And every time they swallow, your tongue expands. And it expands into the teeth. And it makes an indentation. Soft palate. Can you even see it? Is it all the way down the throat? I'm looking at tonsils. So these are called kissing tonsils on the left. And we see that and we know that it's just going to be more challenging for them to breathe. There's just a reduced volume. It's taking up too much space. The Mallampati score was actually invented by an anesthesiologist, and it was a term that he used to try to measure patients' ease of intubation. And what we can see from the patient on the left, which is a class 1, is that you can really see the back of their throat. But when you get all the way to a class 4, the patient opens and you can't even see their throat. It's like the tongue is blocking everything. Well, this is important to understand because class 3 and class 4 Mallampati scores are very high predictors of obstructive sleep apnea. So clinical pictures, tooth wear. Any patient that I see that has pathway wear, I automatically think, do they have a sleep disorder? As a matter of fact, I would even go as far to say there's an airway disorder until proven otherwise. So why do we see pathway wear? If you can imagine that a patient has a more restricted bite, if they need to move their jaw forward to get their tongue out of the way, they're going to rub their teeth unconsciously. The upper and the lower teeth are going to rub and bump into each other. And as their teeth wear, that's going to deepen their bite, which is also going to impact their airway. Erosive wear, I'm going to ask patients, which most of us will, is that do they have reflux? Is there anything that's causing a lot of acid in their mouth? One of the body's reactions to not being able to breathe properly while we sleep is actually the contraction of the diaphragm, which forces acid up into our patients' mouths. So when I see erosive wear or pathway wear, it's making me want to question them about their sleep. Transverse dimensional issue. Now, I understand that there's probably some orthodontists, and there's a lot of back and forth about whether bicuspid extractions lead to a problem with sleep disorder. That's not what this is about. What I'm saying is if a bicuspid extraction case is there, I know that everything is going to be more condensed. And it just makes me ask, do you have a sleep issue? Are you snoring? Do you have trouble sleeping? That's not saying that bicuspid extraction cases are going to, every case is a sleep disorder case. No, not at all. Some patients have to have bicuspid extractions. But there's a fair amount of evidence that's showing that bicuspid extractions can affect someone's airway. And an anterior open bite. A lot of times this occurs because the patient's tongue is trying to get out of the way and they're actually doing self-orthodontics. They're pushing the tongue thrust is causing some of those issues. Now this patient is actually the same one that had a narrow transverse dimension. a vaulted palate. Again, a really quick way that we can see if a patient is narrow in the transverse dimension is you can take a cotton roll, which is about 40 millimeters. And if you put that cotton roll from first molar to first molar, if it fits, they're more than likely okay. But if it's not, I would say maybe they're a little bit too narrow. And again, if they're too narrow, the maxilla is going to greatly influence the mandible. And if the maxilla is narrow, a lot of times you're going to see a narrow mandible as well. And that actually holds true if a maxilla is deficient. A lot of times our mandibles are deficient. So we have a lot of clues that help us start to ask, does my patient have a sleep disorder? Is my patient as healthy as they can possibly be? Can I help them? So what do we do with that information? Well, in my office, for patients that I'm a little bit suspicious, I will use a cardiopulmonary coupling unit, or CPC, combined with a high-res pulse ox. It's very non-invasive, and your patients who have more difficulty sleeping are going to find this a little bit easier to tolerate. And what a cardiopulmonary coupling unit is, it's basically an EKG, and it's measuring the frequency between your heart rate and your respiratory rate. And when they're in sync with each other, the patient's having more stable sleep or deep sleep. If they go out of sync, so imagine you're starting to have trouble breathing, your heart rate may speed up, or your respiration rate will decrease. That signal that's produced will go out of sync. And that tells us that our patient's having more difficulty breathing. Our pulse ox is great because it tells us not only what the heart is doing and how fast it's beating, but it's also letting us know if our patient's oxygen levels are desaturated. So these are very easy, very inexpensive screening devices. And then for our other patients who are a little bit more concerned and are more willing, a home sleep test or even a polysomnogram in a hospital is an excellent way to see if they have a sleep disorder. We can help our patients. We just need to look, we just need to listen, and we just need to help them with directing them in the right place. Now, dentists cannot diagnose sleep apnea. All we can do is become aware of it, and then we would have to refer to a sleep specialist to get that diagnosis. But in the end, we have to fix teeth. And what I want to stress upon you is we have the ability to influence and help patients through our dentistry. And we want our dentistry to succeed, and we want the prognosis to be good. So ultimately, we want to put our patients in the best place that they can do well. I have a team in my office, and my team is an orthodontist, an ENT, an oral maxillofacial surgeon, and my sleep specialists. Each person is critical to helping a patient maximize their health. And that's what this is about. Looking for the clues, asking the questions, and finding the answers. So start looking, because it's everywhere. So, are there any questions that we have at this point? Do I have okay, here, first question. Do I have a myofunctional therapist in my office? Excellent question. So actually my hygienists right now are going through training. I think it's very, very important to have a myofunctional therapist. And what they do is they help train the tongue to get in the right position. If they have a patient has a tongue tie release, they're not going to be used to putting their tongue where it needs to be. And it's very important in order to breathe properly and to get them breathing through their nose, for them to put their tongue in the right position. So yes, for any tongue tie release, I'm referring them to a myofunctional therapist at least a month before and a month after. A lot of my friends who treat Airway have their hygienist or assistants get myofunctional training, and it's a great adjunct to your office. Do I send patients for sleep studies? Absolutely. I have an excellent relationship with my sleep specialists. They're in tandem with me trying to get patients as healthy as possible. I do both sleep studies in a hospital and also at home. I find that for my purposes, I have no problems giving a patient a sleep study, but I have everyone read by a sleep specialist. You also have to check to see how your state allows you to give sleep studies. Every state's a little bit different. So before you start giving out sleep studies, make sure that your state allows that. If your state does not, just sending a patient home with a pulse ox is a great indicator. If you can imagine someone sleeping, if you're looking at their pulse rate during the night, it should be relatively flat. A pulse that's jumping around shows activity. And if they're sleeping, the thing should be relatively benign. The importance of sleep is for our bodies to recover and repair itself. And if our body is working, we're not getting the benefits of sleep. Another question, does snoring indicate an automatic sleep apnea case? No, there can be. Snoring is a sign. It is not a definite indicator. It makes me question. It makes me want to do screening, but there is something that's called benign snoring, which they do not desaturate. Their oxygen levels don't go down. So screening is very important for these patients, but it's not an automatic that they would have that. On the other hand, if a patient has sleep apnea, they're going to be snoring. How long does it take for a hygienist to be trained as a myofunctional therapist? There are 3 schools that you can Google and to get that information. My hygienist was doing one that was going to take about 3 months. Do I charge for a sleep study? Absolutely. I right now have a contract with 2 hospitals in my area where they give me a fee, basically a device fee, and then the sleep specialist gets a read fee. And I do charge their medical insurance or submit their medical insurance. There are companies out there that will help you do that. The company that I work with allows me to be considered an in-network medical provider, which is very helpful for me to reach more patients. What age do you recommend for referral for a tongue tie? As soon as I see it. The earlier that you can fix it, the better. So a follow-up question to the sleep study. Is the sleep study part of my normal diagnostic exam? No. So if there are enough indicators, then I will have a conversation with the patient saying that I'm concerned about their health. And I'll suggest whether it's with me or their primary physician or a sleep specialist that I think it's important for them to screen. The way that I practice is I use a motto that's called show, don't tell. And I use a lot of pictures, and I show my patients what I see, and it really helps them understand more. So I just happen to have pretty much everything wrong with me. I am a sleep apneic patient. I have sleep apnea, and I do treat that with an appliance. So it's real easy for me to share with my patients where my skeletal problems are, and it kind of breaks the ice for them to start asking more questions. If a patient goes through with a cardiopulmonary unit, if they were on board getting help, does that fall under our responsibility to manage, or was it our job to recognize and refer? If a patient comes back with an abnormal study, I'm always going to suggest that they discuss that with their primary physician. In my office, I'm going to immediately try to help them because it's my wheelhouse. I specialize in the head and neck. So one of the things that I'm going to do is I'm just going to try to improve the quality of their sleep. I'm not treating sleep apnea. I'm trying to improve their sleep. So I can start with simple breathe right strips and nasal dilators to help and see if they can do that. I can make an appliance for them to help open up their vertical dimension, or maybe move their jaw a little bit forward. And there's different appliances that can do that relatively inexpensively to see if that improves a patient. But ultimately, if I need to start submitting to medical insurance, then I'm going to need to do further testing and get them to their physician or sleep specialist. So do orthodontic elastics or headgear contribute to obstructive airway? I guess I can tell you the story of my son. So my son had a sleep disorder. We started to get him expanded. And as he went into expansion, he then had a reverse pull headgear. That was putting a little pressure on his mandible, and it did start to affect his airway again. How we treated that was we expanded him more. It's something that you need to be aware of. Am I going to say that it's going to contribute? I don't really think that there's enough studies out there. I just think you have to understand if it could potentially impact, and talk to your patients who are having that if there's a change in their child's sleep habits. Great question by Albert. What type of TMD issues do you find with patients using a sleep appliance? Well, this is going to be one, which came first, the chicken or the egg? Did they have a TMD issue or a sleep issue? Or maybe it's both. So the potential problem that we can have with any type of mandibular advancement appliance that's used to treat sleep apnea is that it is going to put a little compression forces on the condyle and also on the fossa, the anterior part of the fossa. Compression forces can cause bony changes. So what I'm trying to do in my office is, once I'm able to stabilize and treat their sleep disorder, I'm going to talk about ways that they can fix their sleep disorder. And oftentimes that's going to include my team, an ENT to fix a septum, an oral maxillofacial surgeon to maybe fix skeletal deficiencies, an orthodontist to get me more room and greater expansion. So ultimately I'm using my appliances to manage, and then I'm offering my patients a way to fix the problem completely. It is one of the things I discuss with my patients, that they may have joint issues or muscular issues. Most of them resolve, but I think we have to understand that long-term use could potentially affect the joint. I have personally been in mine for 7 years and I don't have a problem. But I have seen cases where some people have had. So someone asked the question, is there a correlation between specific systemic issues and chronic apnea? Yeah, I think, in my opinion, please let me stress my opinion, I think sleep is at the center. And diseases come from the lack of proper sleep, the lack of recovery, the lack of repair. Imagine if you're not sleeping, you're going to be more irritable. You're going to be more stressed. You're not going to feel as rested. There's a lot of research that's being done on autoimmune issues like celiac disease and fibromyalgia, where these patients have affected sleep cycles and poor sleep. And I think if you can help your patients maybe sleep better, I think you're going to find a better health response. Do I routinely make mandibular advancement splints for my patients? So it's a difficult question to answer. I have an Airway protocol and I have steps that I take to help manage someone's airway. One of the things is a mandibular advancement appliance, but that's a little bit further down the line. I think what I'm going to try to do is, if I can get my patient breathing through his nose better or her nose better, what impact is that going to have on their sleep? And I've had a lot of patients say that just by breathing through their nose better and teaching them how to breathe through their nose, that they're getting a better quality of sleep. And in those patients, I will retest them and I'll look and see what their sleep quality is. If that does not help them enough, or if I still need to get better quality of sleep, I start to move into different type of appliances. The first one being just a flat plane. I'm trying to open up vertical dimension. Then what I can do is I can take a temporary appliance like a MyTap or a Sonident Alpha, and I can slowly start to move a patient forward. And maybe that's all they need to do. We're talking about millimeters here. So if I can improve their sleep and decrease any apnea, I'm going to try to do that in the least invasive way. Ultimately, if someone is skeletally deficient, they don't breathe through their nose, I'm going to have to get their tongue out of the way to help them. But the patients are also going to know that a mandibular advancement appliance on its own is not the complete answer. You sometimes need, it's a multifactorial problem, and it needs a lot of different methods in order to treat it. There was one other question that we had, and I believe it was, if my memory serves correct, is there a higher rate of apnea in certain demographics? I think when I look at my patients, I'm looking at their skeleton and I'm looking at their anatomy. And when I talk to patients and I do a medical history and a dental history and a sleep history, you're going to find problems. And maybe I'm one that would say 90% of people have some sort of sleep issue. So are there certain demographics? I'm sure there is, but I think when you combine flow limitation, which is something called upper airway resistance syndrome, in conjunction with sleep apnea, you're going to find a lot of patients that have poor quality sleep. Do I bill patients' dental or medical insurance for CBCT? I am billing their medical insurance. I have every single CBCT read by a board-certified oral maxillofacial surgeon radiologist. Are you liable? Yeah, you take an X-ray, a radiograph, you're liable. I mean, but that's the reason why I send it out to a radiologist. I'm looking at 5 things. I'm looking at their airway volume. I'm looking at their septums. I'm looking at their joints, and I'm looking at their skeletal dimensions. And I let the radiologist look at everything else. So every patient, and there are services out there that you can send your CBCTs to have them read. Like I said, in my office, every single patient that gets a CBCT, it's read by a board-certified radiologist. And I think that about answers all the questions. I'll give 1 more minute if anyone wants to get one last question in. So I hope that tonight was helpful for you to maybe recognize some of your patients that have the potential for a sleep disorder. I hope that you start talking to your patients about the quality of their sleep. And I think if you start looking, you're going to start seeing a lot of your patients that are already in your practice could really benefit from some help. I hope everyone has a good night, and thanks for coming.